In this section, we're going to talk about differential assessment and management of lower extremity wounds. So we're going to start by talking about why it's so important to do differential assessment. And that is because management differs tremendously based on etiology of the wound. For example, if you have a patient whose wound is caused by venous insufficiency, effective management is going to depend to a very large extent on measures to improve venous return, elevation, compression therapy. In contrast, if you have a patient who has an ischemic wound caused by arterial insufficiency, the issue is you're not getting blood out to the tissues. Compression therapy could further inhibit blood flow to the extremity. So compression therapy not only would not help, but it might make things worse. If you have a patient with a neuropathic ulcer, the big focus is offloading and glucose control. So anytime you are consulted on a patient with a lower extremity wound, your number one question, your number one goal is to determine what caused this wound, what's the primary etiology, which in turn will lead you to appropriate management. So we're going to start by talking about arterial wounds, wounds caused by inadequate blood flow to the tissues. These are also known as ischemic wounds. The primary pathology, as you already know, for an arterial wound is atherosclerotic disease. You know that atherosclerotic disease can affect any vessel system in the body. We have a lot of patients with coronary artery disease. We have a lot of patients with cerebral vascular disease. And here's the bottom line. If you have a patient with coronary artery disease, what's the likelihood that they also have some disease involving the arteries to the lower extremities? If you have a patient who's had 2 strokes, multiple TIAs, what's the likelihood that there's also some disease involving the lower extremities? The reverse is true as well. If you have a patient with arterial disease involving the lower extremities, they almost always have some degree of coronary artery disease and cerebrovascular disease as well. So let's look at the mechanisms of injury when you have a patient with atherosclerotic disease involving any vessel. So what's the primary culprit? What starts the whole chain of events? Typically, high levels of circulating lipids. High levels of circulating lipids result in plaque deposits. Those plaques interact with calcium to become harder and thicker. In addition, high levels of circulating lipids cause damage to the vessel wall, endothelial injury. Injury triggers platelet aggregation, triggers release of growth factors. Growth factors tend to cause overproduction of vascular smooth muscle cells. So you end up with a thickened, less elastic vessel wall. So you see here, a normal vessel is wide open, but a vessel affected by atherosclerotic disease has a progressively enlarging plaque that reduces the lumen of the vessel. And what you can't see from that slide is that you also have ongoing thickening of the vessel wall due to the effects of growth factors. The third thing that happens is that when you have a vessel that's damaged by atherosclerotic disease, it starts to secrete an abnormal level of vasoconstrictors. So you have increased production of vasoconstrictors and reduced production of vasodilators, exactly the opposite of what you need. So atherosclerotic disease affects vessel function by narrowing the lumen through plaque deposit, by thickening the vessel wall, which further narrows the lumen and also reduces the elasticity of the vessel, and by abnormal production of vasoconstrictors. So you see the end result, narrow, rigid vessel. Now the other thing that is going on in some situations is that you can get increased blood viscosity, increased coagulability. If that happens, then you have a patient who, in addition to having this very narrow, rigid vessel, is high risk for formation of thrombi that will completely obstruct the vessel lumen. So end result, just what we see in the heart, just what we see in the brain. A narrow vessel that permits only very low levels of blood flow. More significantly, a rigid vessel so that blood flow is fixed. You think with your blood vessels, with my blood vessels. At rest, our vessels are partially constricted because we don't require high levels of blood flow when we're at rest. But if it's break time, and you're going to go to the bathroom, go get something to eat, go get something to drink, check on the kids, whatever, and you're moving very quickly, then the vessels dilate in response to change in metabolic patterns, changes in the need for oxygen. So your vessels change sizes multiple times throughout the day because they're elastic. But if your vessels were damaged by lower extremity arterial disease, they would lose that ability to dilate and constrict, and instead you would end up with fixed rate, low volume blood flow. What does that mean for the tissues? It means that on an ongoing basis, your tissues are on a starvation diet of blood and oxygen. So they're always oxygen hungry. They're barely getting by. If those tissues then sustain an injury, they may not be able to recover. They may not be able to heal that wound because they have barely enough oxygen to maintain. Wound healing is an oxygen-intensive process. If you have fixed-rate blood flow and diminished blood flow, once injury occurs, healing is typically compromised and may be impossible. So that's obviously, I was supposed to flip the slide and I didn't, but we'll just go over this again. So when you have lower extremity arterial disease, also known as peripheral arterial disease, you get reduced blood flow at rest, you get reduced ability to respond to the need for more oxygen. The vessels lose the ability to dilate. The tissues are borderline ischemic at all times, and you can end up with one of two pictures. First, I want you to look on the far right. So here you see a patient who clearly has necrotic tissue, dry gangrene involving the great toe. So with progressive lower extremity arterial disease, you can get spontaneous tissue necrosis. When that occurs, it's going to involve the most distal aspect of the limb, because what part of that limb is furthest from the heart? Obviously the toes. So when you get spontaneous ulceration, spontaneous gangrene, is going to involve the distal toes, the distal foot. The other thing that can happen, and I don't have a slide of this, but you'll see it later on, is what if I have fairly advanced lower extremity arterial disease? So I have minimal blood flow to my tissues at all times. And let's say I'm cleaning up, I'm getting ready for company, and I bump into my coffee table. And I get a little cut. It's not a big cut, it's a very small cut. I bandage it, I put a Band-Aid, maybe some Neosporin because I've seen that on TV. But what's going to happen? Do I have enough blood flow? Do I have enough oxygen to control bacterial loads and to promote wound healing? No. So very commonly you'll have a patient who comes in and they have this big wound, maybe on the anterior surface of the leg, posterior leg. But when you ask them, how did you get this? They're like, well, it's so strange. It started out as a little cut, and it just turned into this big wound, and it won't heal. So 2 clinical patterns related to peripheral arterial disease, lower extremity arterial disease. One is spontaneous necrosis of the most distal foot and toes, and the other is non-healing traumatic injury. Now, risk factors for lower extremity arterial disease you already know very well, because look at this. They're exactly the same as risk factors for coronary artery disease, for cerebrovascular disease. As we've already said, this is a systemic phenomenon. So what do we tell people? Smoking, diabetes, especially type 2 diabetes, hyperlipidemia. So let's look at those big three. Smoking. Smoking can do everything wrong in terms of initiating peripheral arterial disease, lower extremity arterial disease. First of all, it promotes plaque formation. Secondly, it promotes endothelial injury. And thirdly, it's a powerful vasoconstrictor. So those of you who have taken care of patients who have leg ulcers caused by peripheral arterial disease, I know you've spent a lot of time talking to patients about tobacco cessation. And we'll come back to that. Absolutely critical to effective management. What about diabetes? Again, promotes plaque formation, frequently associated with hyperlipidemia, which triggers everything, endothelial injury, plaque formation. Patients with type 2 diabetes have chronically high levels of insulin. Insulin acts like a growth factor, so high levels of insulin promote overproduction of the smooth muscle cells in the vascular walls and the arterial walls, further narrowing the lumen. So diabetes, a major contributor to lower extremity arterial disease. Hyperlipidemia, what's that plaque made out of? Circulating lipids like cholesterol mixed with calcium and other substances. So hyperlipidemia, frequently the triggering factor. The patients who smoke, patients with poorly controlled diabetes, much greater risk. Hypertension, also associated with lower extremity arterial disease. It's not clear whether hypertension is a causative factor or whether high blood pressure and lower extremity arterial disease both result from damage to the vessel wall. But many times when you're reading articles or research reports related to lower extremity arterial disease, they'll talk about those four things: smoking, diabetes, hyperlipidemia, hypertension. Many of your patients with lower extremity arterial disease will present with all four of those risk factors. Now, there's other risk factors as well. Age. Approximately 30% of the population over 66 years of age have lower extremity arterial disease. Of course, age is also associated with increased incidence of coronary artery disease and cerebrovascular disease. Most of your patients are going to be older. The exception, your diabetic patient, who is frequently younger. Obesity is associated with coronary artery disease, cerebrovascular disease, and lower extremity arterial disease. In part because of increased incidence of diabetes and all of those risk factors. Many times your obese population, when you look at their blood work, they also have hyperlipidemia. Family history. Most risk factors are modifiable. So can I control my use of tobacco? Yes, hopefully. Can I do a better job of controlling my diabetes? Yes, if I really get why it's so important. What about hyperlipidemia? Can I modify my diet? Can I take statins? Yes. Hypertension? Yes. What are the non-modifiable risk factors? My age, I can't fix that. And my family history, I can't fix that. But I can be aware. So if I have a lot of coronary artery disease, cerebrovascular disease, lower extremity arterial disease in my family, very important for me to avoid tobacco use, to control my blood pressure, to control my weight, to control my diabetes. Interestingly, they have found in recent studies that patients who have chronic inflammatory states are higher risk for lower extremity arterial disease. And there's a lot of research ongoing looking at the link between chronic inflammatory conditions and arterial disease. And finally, elevated homocysteine levels. Elevated homocysteine levels are associated with increased coagulability, increased risk of thrombus formation. But fortunately, it's very treatable with vitamin B6, vitamin B12. So many vascular surgeons, in working up a patient for lower extremity arterial disease, will do lab work and will look at homocysteine levels and will treat those levels if they're elevated. Now, we said that diabetes is a major risk factor. If you have worked in an outpatient wound center and you see a lot of patients with lower extremity arterial disease, I am betting that the majority of those individuals are diabetic. So we know there's a very close connection between diabetes, especially poorly controlled diabetes, and lower extremity arterial disease. I wanted to just briefly talk about the impact of coexisting diabetes on the severity and the prognosis of lower extremity arterial disease. So first of all, we've already said that you're likely to see arterial ulcers, clinically significant arterial disease, at a younger age in the diabetic population. Non-diabetics, almost always over 66. Diabetics, frequently younger than that. Also, in the diabetic population, the male-female ratio is essentially 1-to-1. You're going to have just as many women as men. Whereas in the non-diabetic population, lower extremity arterial disease, much more common in men, probably because of the increased use of tobacco in the male population. Look at points 3, 4, 5, and 6. These impact tremendously on prognosis. So diabetics are much more likely to have disease that involves both legs, multiple arteries, multiple segments of the artery. Whereas in the non-diabetic population, they'll frequently have disease that involves one vessel on one leg. So those of you who have worked vascular units, you've had many patients who came in for a right-sided femoral popliteal bypass graft because they had one area that was narrowed and they could just bypass around it. But in the diabetic population, it's much more difficult to do effective bypass surgery because it's likely to involve proximal arteries, distal arteries, large arteries, mid-sized arteries, and sometimes even the small vessels. So much more complex, much more difficult to manage. We've already said they're more likely to have disease involving the mid-sized vessels as opposed to the large vessels. So when you think femoral popliteal bypass, those are large vessels, femoral artery, popliteal artery. But the diabetic population is much more likely to have disease involving the tibial arteries and the perineal arteries. And those are the vessels that supply the lower leg, the foot, and the toes. Most significantly, lower extremity arterial disease in the diabetic population is much more likely to be severe and to result in limb loss. And one of the very negative factors in lower extremity arterial disease in the diabetic population is the fact that in addition to involving mid-sized vessels, you might get involvement of small vessels. So small vessels are those little arterioles, and you cannot bypass small vessels. You can bypass mid-sized vessels with disease as long as there's a patent distal vessel, but if you have disease involving the small vessels, there's nothing that can be done surgically. So again, let's look at the vessels that are involved. And the slide on the right just shows you exactly what the vessel starts to look like, and you can visually see a marked reduction in the lumen of the vessel. What you can't see is that that vessel is also rigid and the vessel wall is thickened. So Mid-sized vessels very likely to be affected. So when you look at the tibial artery, which branches that form the posterior tibial and the dorsalis pedis, that's a major vessel, and then there's a perineal that's also a mid-sized vessel. When we talk about small vessel disease, though, we're talking about these arterioles, these very small vessels branching off of major arteries and feeding into the capillary bed. And you can see that it would be impossible to bypass diseased small vessels. This also helps to explain why sometimes you'll have a patient who has a palpable dorsalis pulse, maybe both a palpable DP and PT, and yet they have necrosis of the distal toes. That's small vessels that supply the distal toes. So sometimes, even though your mid-sized vessels are at least partially patent, the distal small vessels are very diseased, and you can still get significant tissue death. We've talked a lot about atherosclerotic disease because that is the most common cause of ischemic ulcers, arterial ulcers. But it's not the only cause. So you want to remember that there are other etiologic factors for arterial disease. Some of you will deal a lot with patients who have sickle cell disease. You know that patients with sickle cell disease are at risk for vessel occlusion during crisis. So what happens when a patient with sickle cell disease becomes acutely ill and goes into sickle cell crisis? Anything that affects oxygen levels causes those little red blood cells to curve and to form the sickle cell shape and then to clump. Those clump vessels then occlude distal arteries and cause ischemic ulcers. Now, once the crisis has been resolved, blood flow returns to normal. So many times we can get those wounds to heal over time, but if the patient goes back into crisis, they're at risk for recurrent ulceration. How many of you have taken care of patients who are septic or who are post-septic shock, and they have patchy areas of ischemia? Like sometimes you'll see patients who have gangrenous toes, or maybe the tips of the toes are gangrenous, or maybe even just one little area of tissue is gangrenous. We frequently see patients who are status post-septic shock. They have required vasopressors, and as a result they lose their toes, sometimes their fingers, maybe all of their toes, maybe just some of their toes. Depends on which vessels totally shut down during the shock episode and in response to vasopressors. So you think about the negative impact of septic shock and vasopressors. So septic shock, now your pressure drops, your perfusion is diminished. You add vasopressors to the mix. What do vasopressors cause? Shut down of the peripheral circulation. So now you've clamped down on the vessels that feed fingers and toes. So you may see patterns like this where you have ischemic damage. Sometimes you'll get arterial ulcers as a result of vasculitis or vasculopathy, and we'll talk a little bit more about that when we talk about atypical lower extremity wounds. But as a wound care nurse, you're going to be consulted on many, many different types of wounds. Anytime you see gangrene of the tissues, anytime you see dry eschar, anytime you see this purple discoloration, you know you're dealing with ischemic disease. Clearly, these tissues lost blood flow, lost oxygen. Most common reason, arteriosclerotic disease, not the only reason. So you're always looking back to see what would have caused loss of blood flow to these tissues. Now, a big challenge for you is to accurately determine etiology of a lower extremity wound. So when you go in to see any patient with a lower extremity wound, you're going to ask some key questions, and you're going to do some critical assessment of vascular status. One of the questions you'll always ask is, do you have pain associated with this ulcer? If yes, when does the pain occur? What makes it better? What makes it worse? How severe is it? The patient with ischemic disease is going to tell you that activity always makes it worse. Elevation almost always makes it worse. That makes sense, doesn't it? If I've got low volume blood flow and a fixed rate of blood flow, so I'm unable to respond to changes in tissue metabolism and unable to dilate when increased oxygen, increased blood flow is needed, maybe I'm okay at rest when I have low demand for oxygen and for blood flow. But what's going to happen if I take a brisk walk down the hall? What's going to happen if I go up the stairs? Is that fixed rate of blood flow going to meet the muscle's needs for oxygen? No. So they'll tell you, I'm okay if I'm sitting. I can walk a few steps, but if I have to walk very far, I start hurting. If I have to walk fast, I start hurting. So you'll hear things like, I got my son to drop me off at the doctor's office because I knew I couldn't walk from the parking lot to the office. It would cause me too much pain. I used to could walk to my mailbox, but it's down a long driveway, and I can get down, but I can't get back up. So increased pain with activity. Typically, they'll tell you if I just stop and sit down, in about 10 minutes, it gets better. That is classic arterial pain, also known as intermittent claudication. Now, with large vessel disease, like you see in your patient who comes in for a femoral popliteal bypass graft, they'll complain of calf pain because pain occurs one joint distal to the involved artery. If you have a patient with lower extremity disease, they'll complain of foot pain. They'll say, you know, my feet just kill me when I have to walk. So pain that's worsened with activity, at least partially relieved by rest. What about elevation? How many nurses routinely tell patients with any kind of lower extremity wound, put your feet up, because we're thinking, oh, that'll improve venous return, it'll reduce edema. But what happens to the patient with arterial disease when they put their leg up? Now the blood has to flow uphill. So not only do you have a narrow vessel, not only do you have a rigid vessel, but now you're asking that blood to go uphill instead of down. Watch patients. They will assume the position of greatest comfort. So they will automatically sit with their legs down. Here's the other thing you'll hear. You'll hear patients saying, I don't sleep in the bed. I used to sleep in the bed. I wish I could sleep in the bed. I'm so tired of sleeping in the chair, but I have to. When I go to bed and I put my legs out flat, in just a few minutes, I'm hurting. And the only thing that makes it better is if I sit up. So I go and I sit in my recliner and I sleep in my recliner with my legs down. Once you get to rest pain, where you have pain at rest, pain even with dependency, your vessel is almost totally occluded. Rest pain means 90% vessel occlusion. So pain patterns, very instructive. It tells you so much in terms of the primary etiologic factor. I have to tell you a funny story. I had one patient and I was talking to him about his pain, and I was asking him what made it better and what made it worse. He looked like he had arterial disease, and the initial things he was telling me made me think he had arterial disease, but then he said, well, what makes it better is my Camel cigarettes. Well, he saw the look on my face. He's like, I can see you don't believe me. Nobody believes me. But it's the truth. He's like, here's what happens. I go to bed, I'm okay. 20, 30 minutes later, I wake up, I'm in pain. I sit up, I grab my cigarette. By the time I take the third or fourth drag on my cigarette, I'm feeling so much better. Well, of course, he was feeling better because now his legs were dependent. Do you think he wanted to believe that? No. Those cigarettes were going to get all the credit for pain relief. So pain, very instructive. Now, many times you have a patient who has both diabetes with neuropathy and arterial disease. And so when the patient says, yes, they have a lot of pain, you've got to try to distinguish, is this ischemic pain, is this neuropathic pain? Neuropathic pain also frequently gets worse at night. But here's what makes it better. Getting up and walking. The reason neuropathic pain is worse at night is because there's no other signals to drown out the neuropathic pain. But if the patient gets up and walks, walking and all of the signals related to walking tend to drown out that neuropathic pain. So if the patient tells you that walking makes it better, it's almost always neuropathic. If walking makes it worse, it's almost always ischemic. Okay, so you talk to the patient, you ask them about their history. Do they use tobacco? Are they diabetic? How well is their diabetes controlled? Do they know what their cholesterol levels are? All of that kind of stuff. You ask the patient about onset of the wound. What triggered onset of the wound? Has it been getting better or worse? You ask the patient about their pain pattern. How bad is their pain? What makes their pain better? What makes their pain worse? Now you're going to assess the limb and you're going to assess the wound. In assessing the limb, you're looking for evidence of compromised blood flow. So the first thing you look at is the lower extremity in general. You're always comparing left to right and proximal to distal. Look for signs of chronic tissue ischemia. Well, what would be indicative of chronic tissue ischemia? So you think you have to have blood and oxygen to make new skin cells. You have to have blood and oxygen to grow hair. You have to have blood and oxygen to grow nails. So, signs of chronic tissue ischemia, that very thin, shiny skin, abnormally thin epidermal layer because there's not enough blood flow to make skin cells at the normal rate. Diminished or absent hair growth. So you'd ask the patient if there's no hair growth on the lower leg. You want to ask them, is this different? Did you used to grow hair and now you're not growing hair here? Again, compare right to left, you see a difference. Compare proximal to distal. So changes in the patterns of hair growth. If I've never had much hair on the lower extremity and I don't have much hair, it doesn't mean anything. But if I had a lot of hair and now I have very little, that's very significant. If I have hair on the left leg but not on the right, very significant. So you're looking for changes in patterns of hair growth. So thin, shiny skin, diminished or absent hair growth as compared to my usual patterns. And then what about nails? So do my nails look normal or are they very thin with little grooves, little ridges in the nail? If they're very thin and ridged, that's indicative of chronic tissue ischemia. Now, many times, your patient will also have diabetes, and your diabetic patient is very high risk for a fungal infection of the nail. And fungal nail infection tends to make the nails thick and discolored. So if they have a fungal nail infection, it will totally mask the effects of ischemia on nail growth. You won't be able to use that as an indicator. color also tells you a lot. So remember way back when you were learning about indicators of hypoxia, ischemia, and we talked about circumoral pallor or cyanosis, so blue lips, pallor. With the lower extremity, if I'm sitting down and you see this dark red purple color to the extremities, that's known as dependent rubor, and it's because of that fixed rate of blood flow. But if you elevate the leg in a patient with significant arterial disease, you'll get elevational pallor, a chalky white color to the skin in a patient with light or mid-tone skin, or it might look ashen or gray-toned in a patient with dark skin. So if you're seeing that patient in the clinic, in the hospital, very helpful to elevate the leg to at least 60 degrees. Watch for color change. Have them sit on the side of the bed with the legs dependent. Watch for a color change. Elevational pallor, dependent rubor, classic indicators of arterial disease. We always check temperature. Now, a lot of you have chronically cold feet and it doesn't mean anything. But again, checking proximal to distal and comparing left to right. If there's a major change in temperature, checking with the back of your hand. If you notice a major change in temperature, that's certainly indicative or suggestive of arterial compromise. And then there's a test called venous filling time test. If you elevate the leg, obviously I'm pretending this is my leg, if you elevate the leg until all of the veins collapse, and then you put my leg down and you count the number of seconds it takes for my veins to refill, that gives you an indicator of arterial perfusion, because once you empty the veins and then you put the leg back down, venous filling originates from the capillary beds, which are fed by the arterial circulation. If it takes more than 20 seconds for my veins to refill, that's indicative of clinically significant arterial disease. So first you ask me key questions about my history, about onset of the wound, about my pain pattern. Then you start the physical exam and you look for indicators of chronic tissue ischemia, okay? What does my skin look like? Is there any change in the patterns of hair growth? What do my nails look like? What happens when you put my leg up? Is there a color change? What happens when you put my leg down? How long does it take for my veins to refill? And is there a change in temperature when you're checking knee to ankle? Then you're going to do very objective measurements. You're going to assess pulses, and you're going to do an ankle brachial index study. Now, the two critical pulses to check are dorsalis pedis and posterior tibialis. If you're doing a full vascular exam, you would of course start with the femoral, then go to the popliteal, then to the DP, and then to the PT. Many times, you're very short of time, and so you'll start distally instead. If I have a normal dorsalis, a normal posterior tibialis, then I know that I'm getting blood flow through the popliteal and through the femoral. So if you're short of time, start distal. But I just wanted you to notice what the patterns of these arteries are, because this is where you're going to check when you're doing your pulse checks. So dorsalis pedis tends to run between the first and second toe and over the arch of the foot. So many of us will start here because that's where it's most likely to be felt. If it's difficult to palpate here, then we'll move up toward the toes and down toward the ankle. The posterior tibial runs along the inside of the ankle, right behind the medial malleolus. So check your own pulses so you can see exactly where your DP runs and where your PT runs. Now, a couple of things. Even if you have good pulses, remember it does not mean that your small vessels are healthy. It simply means that you have enough blood flow through the mid-sized vessels to generate a pulse. What if you get a good PT, but you can't palpate the dorsalis pedis? There's actually a small percentage of the population where the dorsalis pedis is not palpable, just because of the pathway that the vessel runs and the depth in the tissues. So if you cannot palpate a DP, but you palpate a very normal PT, and the tissues look healthy, and there's hair growth, normal venous filling time, then that patient obviously has adequate perfusion and no clinically significant arterial disease. However, if you're unable to palpate a DP, unable to palpate a PT, absence of those two pulses is independently indicative of clinically significant arterial disease. So pulse palpation, a very important component of your vascular exam, but not a standalone indicator of total vascular health. One of the most effective and objective measures of arterial perfusion to the lower extremity and the foot is the ankle brachial index. When you're on site, you'll actually practice doing an ankle brachial index test on your classmate, because we want to make sure that you understand how to do this test correctly. Multiple studies have shown that a correctly done bedside ankle brachial index measurement is a very effective and accurate screening measure for lower extremity arterial disease. Can be done with anyone who understands the procedure and who has a bedside Doppler. So what's involved? Well, first of all, you put the patient at rest for 10 minutes in the supine position. Then you're going to obtain the brachial systolic pressure, both right arm and left arm, using the Doppler stethoscope. Then you're going to put the blood pressure cuff around the lower leg, and you're going to use your Doppler stethoscope to get a systolic pressure over the dorsalis pedis, and then over the posterior tibialis in the right leg, and then the left leg. You should end up with 6 pressures: right brachial, left brachial, right DP, right PT, left DP, left PT. Then you're going to mathematically compare pressures in the brachial vessels to pressures in the pedal vessels. And this is how you do it. You use the highest of the 2 brachial pressures as your denominator for both right and left. So let's say my right brachial was 110, my left brachial was 120. We're going to use 120 as the denominator for both the right and the left brachial. For both the right and the left ABI. Then you take the higher of the 2 pressures on the right. So let's say 120 is my denominator. And let's say that my PT is 90 and my DP is 80. So we're going to put 90 over 120 because we're comparing blood flow to the foot and blood flow to the arm. 90 over 120. I picked those numbers on purpose because it's easy to do the math. So clearly that would give me an ABI of 0.75. Okay? 9 over 12. Now, 0.75. Is that good? Well, ideally, we would like the blood flow and the pressures to the lower extremity to be essentially the same as blood flow and pressures to the upper extremity. So we'd like it to be right at 1. But it's not 1, it's 0.75. So that's like, well, the lower extremity is getting about 3/4 of the blood flow that the upper extremity is getting. Sounds like I have some arterial disease. In contrast, if the pressures in the lower extremity were 124, pressure upper extremity was 120, the ratio is going to be right at 1.00, which is perfect, just where it should be. Now, how do we interpret the results? So again, they should be essentially the same. Perfusion to the lower extremities should be essentially the same as perfusion to the upper extremities. So the closer your answer is to 1.00, the better. And of course, we don't expect you to do long division. We expect you to use your phone calculator. So I'm going to go through this, and then I'm going to use a couple of examples, and hopefully that will help you put it all together. And again, we'll do this on site. Normal, 0.9 to 1.3. We've already said that lower extremity, upper extremity pressures, lower extremity, upper extremity blood flow should be essentially the same. Many times you'll find that the pressure readings are slightly higher in the lower extremity, so that's why you see a range of 0.9 to 1.3. If it's 0.8 to 0.9, think of that as 80 to 90% of blood flow, blood pressure compared to the arm. What does that mean? It means that you have mild lower extremity arterial disease, but you still have enough blood flow to support healing. You still have enough blood flow to support tissue health. You have enough blood flow and high enough blood pressures so that you can tolerate compression therapy if you need compression therapy. As you drop down 0.5 to 0.8, what does that mean? Well, 0.5 is about 50%, or is 50%. It means that the blood pressure in the lower extremity is half the pressure in the upper extremity. And of course, that suggests that blood flow to the lower extremity is about half the rate of blood flow to the upper extremity. So 0.5 to 0.8 means you have moderately severe lower extremity arterial disease, borderline perfusion. You still have enough blood flow to maintain tissue health. You probably have enough blood flow to support healing, but it will be slower and much more problematic. What about compression therapy? If that patient has significant edema and requires compression therapy, we should use modified, lower level compression therapy because this vessel is compromised. It's more easily compressed, and we don't want to reduce arterial blood flow. So 0.5 to 0.8, significant disease, you need to do a vascular consult. If the patient needs compression therapy, you should use a lower level of compression, what we call modified compression. We'll talk more about that in the class on venous disease. What if the ABI is less than 0.5? Well, now we're into very significant arterial disease. What if the pressure in the arm is 120, pressure in the lower extremity is 60 or less? Like, wow, that is really significant interference to blood flow. I've got to get that patient in to see vascular as soon as possible. I can't expect that patient to heal any existing wound, and I absolutely cannot use any compression. What if it's less than 0.4? That's considered to be critical limb ischemia. That patient's at very high risk for limb loss unless we can do revascularization. What if it's abnormal on the other end? What if it's higher than 1.3? Well, that means that you have some degree of vessel calcification, and so it's very hard to compress the vessels. Anybody with an ABI greater than 1.3 requires a vascular consult. Some patients will have non-compressible vessels. So you've pumped the cuff up to 200, 250, and you still get the signal, stop and label that patient non-compressible. And yes, they get an urgent vascular consult. So who gets a consult? Let's drill it down. ABI is a screening tool. So you check pulses, you check ABI. Then you determine, based on your ABI results, who needs a vascular consult and how urgent should it be. Anybody with an ABI less than 0.5, gets urgent vascular consult. Patients with ABI over 1.3, urgent vascular consult. Their vessels are calcified. I don't know how much blood flow they're getting. Any patient who has clinical indicators of significant ischemia, pain at rest, non-healing wounds, they need an urgent consult no matter what their ABI says. So what if I have a patient with a non-healing wound? What if I have a patient with significant ischemic pain? They're sleeping in their recliner, but their ABI comes out 0.7, doesn't look so bad. They still need a vascular consult. We have to remember that patients with diabetes, patients with end-stage renal disease, very high risk for vessel calcification, and that alters and skews your ABI results. So when you have calcified vessels, your ABI results are not accurate. So anybody with ABI less than 0.5, urgent consult, greater than 1.3, urgent consult, clinical signs of ischemia despite, relatively, non-scary ABI, urgent vascular consult. Also, and it's not on this slide, but just as a reminder, if they're somewhere between 0.5 and 0.8, yes, they should be worked up by vascular. It's not as urgent as ABI less than 0.5 or greater than 1.3, but they still need a workup. Okay, what other studies might be done to provide additional insight into vascular status, into adequacy of perfusion? What studies could be done to further guide therapy? We talked about ankle brachial index, comparing ankle pressures to brachial pressures. There's also a study known as toe brachial index, comparing toe pressures to pressures in the brachial arteries. Now, first of all, these studies are not easy to obtain. There's this little tiny toe cuff and a pencil-style Doppler. Very hard to do. I remember sitting on the floor of my office trying to learn how to do this with my colleagues. Very difficult to do. Why do they recommend a toe brachial index, and when do they recommend toe brachial index? They recommend a toe brachial index if your ABI indicates calcification. So if your ABI is greater than 1.3, they recommend a TBI. Why? Because the toe vessels are much less prone to calcification. So TBI would not be helpful if they had a very low ABI, but could be helpful if they had a high ABI. Here's the problem, and I was so glad to read this study. It is very difficult to get a valid toe brachial index reading with a handheld Doppler. So the recommendation is that TBI studies should be done in the vascular lab. So if you have a patient with an abnormally high ABI, they should be referred to vascular, and vascular will have additional studies done in the lab. What's normal? They might ask you that on the certification exam. Well, toe pressure should be higher than 30. If they're less than 30, that's indicative of arterial disease. One of the most valuable tests you can obtain is TCPO2, so transcutaneous oxygen levels. Why is that so important? Because now instead of measuring pressures, we're actually measuring oxygen delivery to the tissues. Pressures are going to give you a pretty good handle on the health and the patency of your mid-sized vessels. But ABI does not reflect small vessel patency, tells you nothing about small vessel disease. In contrast, TCPO2 tells you how much oxygen is actually getting out to the tissues. That is, if I had to pick one test and I could have it on anybody, I would pick TCPO2. Now, this is not something that nurses do at the bedside. It requires more specialized equipment, so it's typically done in the vascular lab or in hyperbaric oxygen centers. But you can see why it's such a valuable test, because it measures the end result of perfusion, how much oxygen is getting out to the tissues. And it's a reflection of both mid-vessel health and small vessel health. Now, what's normal, what's abnormal? If you've got TCPO2 readings above 40, that's normal. They should heal normally, and it pretty much rules out arterial disease. If their TCPO2 is between 30 and 40, that's kind of an indeterminate value. They may or may not heal. There's definitely some evidence of ischemic disease. If their TCPO2 is less than 20, they won't heal. Sometimes they use that as an indicator for level of amputation. So they'll do TCPO2 measurements at different levels on the leg, and they want to cite the amputation where the levels are always above 30 and hopefully above 40. Other things that can be done that will be done by the vascular surgeon or by an NP is to do auscultation of larger vessels for bruits. That just tells you, are the larger vessels developing disease. Sensory assessment, and we'll talk more about sensory assessment when we talk about neuropathic ulcers, but sensory function can be adversely affected by microvascular disease. So if you're concerned about small vessel disease, it can be very helpful to test to see, does that patient have normal sensation. But if I had to summarize the most critical assessment data that you want to do for every patient who comes in with a lower extremity wound, you've heard it before, I'll keep going over it. Okay? You want to know what's their medical history, so you know what their risk factors are. Are they a smoker? Are they diabetic? What's their cholesterol level? What's their blood pressure? You want to know how long they've had the ulcer and how it started. You want to know how severe their pain is and what makes it better and what makes it worse. You want to look at the tissues in general. Does it look like they're getting good blood flow to the lower leg, to the feet, or do they have that thin, shiny skin, very limited or absent hair growth, thin, rigid nails? What happens when you put their leg up and down? Are there color changes? If they've got healthy vessels, the color will not change when you put them up or down. But if they have arterial disease, they're going to get elevational pallor or ischemia or cyanosis, that ashen blue tone. And when you put the leg down, they'll get that deep into rubor. You want to check venous filling time. How long does it take after my veins collapse for them to refill? You want to check pulses. You want to check ABI. If you have significant indicators of arterial disease from your basic vascular screening exam, you're going to refer that patient to a vascular surgeon, and additional studies are going to be done, which are likely to involve toe brachial index, TCPO2. Now, there is a condition known as critical limb ischemia. You'll see this in many sets of guidelines, many articles, many research studies. And what they mean is a collection of assessment indicators that tell you the patient is very high risk for amputation if nothing can be done to turn them around. So there's three major indicators. One is chronic rest pain. Even at rest, Even with my legs down, I'm having pain. My vessel is more than 90% occluded. Or I have an ulcer that's not improving at all, not improving even slowly, or I have gangrene. When you do my ABI, my ankle pressure is less than 50, or my ABI is less than 0.4, and my TCPO2 is less than 30. Now, what does this mean for us? These are the two pieces of data we would have ready access to. What's their pain pattern? What's happening with their ulcer? Do I see any gangrenous changes of the tissues? And what was their ABI? So if I see either of these, they're going to vascular for an urgent workup, and they'll get the TCPO2. Why is it so important to identify the patient with critical limb ischemia? Well, look at these stats. 1 year mortality is greater than 20%. That's pretty significant. 50% of those patients are going to require vascular surgery, revascularization. 40% will end up with amputation. So with 40%, it's not possible to do effective revascularization, and they do lose the limb. Bottom line, we see indicators of critical limb ischemia, we get vascular on board now. Okay, so we've talked about indicators of ischemic disease. Now let's talk about indicators of arterial ulcers. Because one of the things we're looking at is the ulcer. So we look at the leg, we look at the butt, we do all of the checks we've talked about. Now we're looking at the ulcer itself. Location, location, location. Very, very important part of assessment of any lower extremity wound. If it is caused by arterial disease, where is it going to be? It's going to be distal. It's going to involve the distal foot, the toes, or it's going to be a traumatic injury that failed to heal. You might also have a non-healing pressure injury. So if your patient's bedbound, they might have a heel ulcer, and that heel ulcer is not improving, is not resolving, because there's not enough blood flow. So either you're going to have distal location, or you're going to have a non-healing traumatic injury or a non-healing pressure injury. What's the wound bed going to look like? Go back to the fact that there's minimal blood flow. So the ulcer bed is either going to be pale or it's going to be necrotic. Most of your arterial ulcers will be small and deep, and they'll have kind of a punched out appearance, very clearly defined ulcer margins. So that's one of the things you look for. Most of them have minimal exudate, because where does exudate come from? The bloodstream. And they have minimal blood flow. So they have pale, dry, frequently necrotic wounds. This is a very important point. A very high percentage of arterial wounds are infected because there's not enough blood flow, not enough oxygen to control bacterial loads. But the signs and symptoms of infection may be extremely muted because you don't have enough blood flow to create brisk erythema. You don't have enough blood flow to contribute to significant induration. I can't tell you how many times I've missed infection in an arterial wound because the signs were so subtle. So you always actively assess for signs of infection. So on the far right, you see dry gangrene, dry eschar of the distal toes. If you come over, you see eschar of the great toe, gangrenous changes involving the great toe. You also see an ulcer on the dorsal aspect of the foot, and you see a lot of erythema suggesting infection. This wound was caused initially by trauma, non-healing because of significant arterial disease, but faint halo of erythema. So you're very alert to subtle indicators of infection. All of these are arterial. Again, if you look at the far left, so you've got total dry gangrene of the second toe, total desiccation. You've got gangrenous changes, eschar involving the great toe and the third toe. If you look at the mid slide on the top, you see a non-healing pressure injury, and you see erythema all the way around. Far right, we've already talked about faint erythema. The bottom two slides came from the Diabetic Association. This was a patient with diabetes, neuropathy, and ischemic disease. On initial presentation, this ulcer didn't look so bad, but when a cotton-tipped applicator was used to probe, there was circumferential undermining. There was very faint erythema. When they debrided based on CT, you see how much tissue was actually involved. So again, very high index of suspicion for infection when you're dealing with arterial wounds. Okay, in the last 10 or 15 minutes, we're going to talk about management. How do we manage these wounds? Well, the underlying problem is not enough blood flow to the tissues, and our number one goal is to try to turn that around, to improve blood flow. So we can't do that. I can't magically improve blood flow. There's not a dressing that's going to do that. I have to involve vascular. And vascular is going to look at the patient and is going to determine, can we, should we improve perfusion surgically? Should we use medications? Should we use a combination? So, first question typically is, can we revascularize? And revascularization involves either a bypass procedure, but to do a bypass procedure, we have to have patent distal vessels. So we have to be able to swing around the area of obstruction. The other thing that is frequently done is angioplasty. And usually when they do angioplasty to open up the vessel, they insert a stent to try to keep the vessel patent. So it can either be bypass or angioplasty. Now, if they do a bypass, they can either use a synthetic artery or they can harvest a vein and use that. If they use the patient's own vessel, it has a lower risk of occlusion than a synthetic graft. So many times you'll see them try to use a vessel, a vein from the patient. They can occlude as well, but they have a lower rate of occlusion than the synthetics. So can they revascularize? Can they do angioplasty and put in a stent? So they may or may not do a vascular procedure. Almost all patients will be placed on medical therapy, will be placed on pharmacologic agents to improve perfusion. This is true of patients who are bypassed or who undergo angioplasty and those who are not candidates. So cilostazol is one of the most commonly used medications. You might know this as Playtol. A lot of studies have been done on this drug. It's been shown in multiple studies to reduce pain, to improve walking distance, to improve the patient's ability to tolerate activity. However, it may be contraindicated in the patient with heart failure. So it always requires a comprehensive look at the patient to say, is this feasible for this individual? Almost all patients will be placed on statin therapy to reduce the levels of circulating lipids to try to prevent further plaque formation. Also, statins have been shown to improve walking distance and to reduce the incidence of cardiovascular events. What about aspirin? Aspirin is sometimes used not because it improves outcomes related to lower extremity or arterial disease, but because it reduces the risk of disabling or fatal stroke. And finally, antiplatelet drugs like clopidogrel also reduces the risk of fatal vascular events, fatal MI, fatal stroke, and can be given in conjunction with aspirin. So you might see the patient on both aspirin and clopidogrel. So some patients will have surgery. All patients will be placed on some medications to improve perfusion, reduce the risk of fatal or disabling vascular events, and hopefully improve walking tolerance, reduce pain. The next thing that is typically prescribed is a walking program. Now you think about the patient who comes in with an MI, and first we get the patient stable, we let the heart recover, and then we put them in cardiac rehab. And what's our goal? Our goal is to improve perfusion to the heart, and that's exactly what we want to do with a walking program for the patient with lower extremity arterial disease. Now again, when I have that patient up walking, is going to increase demands for blood flow and for oxygen. When the patient has an open wound, I want all available blood and oxygen going toward healing of that wound. So we typically don't begin a walking program until the ulcer is healed or almost healed. But then we want them on a walking program. We want to develop collateral vessels. We want to improve the efficiency with which the leg muscles use available oxygen. And there's great data to support the effectiveness of structured walking programs. So they've been shown to significantly improve exercise tolerance, to significantly reduce pain. We talked about waiting till the wounds are healed. How often should they do it and for how long? So typically they'll do their structured walking 3 times a week, 30 to 60 minutes at a time. They usually walk on a treadmill to the point of pain, rest until the pain resolves, and resume activity. Now they've done studies comparing structured walking programs under supervision where you go to like the clinic. Most cardiac rehab programs are done in a clinic. Your structured walking program can also be done in a clinic, or where it's done with a very structured prescription and the patient reports on their adherence to the program. Any structured supervised program, any level of supervision, provides better results than just saying to the patient, here's what we want you to do. We want you to walk 30 to 60 minutes, 3 times a week, walk to the point of pain, stop, resume. Makes sense, doesn't it? Because if I have to come to the clinic to participate, if I have to demonstrate in some way or another that I actually did this, if I have to show my, wear my Fitbit or whatever, then I'm much more likely to adhere to the program than if you just tell me to do it and I say I'll try. So you want to build in some accountability. Bring them back in, have them wear some kind of monitoring recording device where they can submit their data. We also have some very important lifestyle modifications that we need the patient to incorporate. So this requires intensive patient education. Tobacco use cessation. Now we've talked about this in previous classes, so I won't go on and on. But for the patient with arterial disease, this is one of the most critical elements of therapy. I cannot make this patient's decision for him or for her. And I'm going to tell them that up front. I'm going to say to them, I'm going to talk to you about some things that significantly impact our ability to get this wound to heal. I am not telling you what to do because that's your decision. you have to make the decision based on what's going on in your life, your overall priorities. But it's my responsibility to let you know how smoking, how tobacco use impacts on blood flow to your leg and to your foot and on our ability to heal the wound. And then you've got to tell me whether healing the wound is a high enough priority for you to work at tobacco cessation, and if so, how I can help you. We want them to maintain hydration. Hydration reduces blood viscosity, improves blood flow. So I want to talk to them about fluid intake across a 24-hour period. Remember, many of these patients are older, and we know that older individuals frequently do not get in enough fluid. So hydration is a very simple lifestyle modification, but it's usually going to be the nurse, and especially the wound care nurse, who thinks to bring this up with the patient. Tight glucose control, back to the same issues. It's a lifestyle modification. The patient has to understand, why does this matter? Why am I asking you to get on board with tight glucose control, at least so we can get this one to heal? And what does tight glucose control mean? Ideally, blood sugar is less than 140, definitely less than 180. Okay? And then dietary modifications. Now, we don't have great data on this. We certainly know we want them on a low lipid, low cholesterol diet. Some studies indicate improved perfusion with high doses of niacin. Not everyone can tolerate that. Our data's not great. So most of the time we're talking to them about a balanced diet that supports healing and lowering lipids. So priority number 1, improve perfusion. Might involve revascularization or angioplasty, bypass or angioplasty. Almost always involves medications to reduce lipid levels, to reduce clot formation. It involves lifestyle modifications, so a progressive walking program, hopefully tobacco cessation, hopefully tight glucose control, adequate hydration. All of that's about improving blood flow to get the wound to heal. Now, the second priority is to prevent further injury, because we know they're borderline. Their ability to heal is very compromised. So we've got to start building in prevention. So we want to tell them, you're very high risk. We want to keep you from damaging your leg, your foot, because once you sustain an injury, we may or may not be able to get it to heal. So they should wear protective footwear when they're out of bed. If they're working around the house, working in the yard, they should wear shin guards. They shouldn't be going to the nail salon where they risk injury that would result in infection that could result in limb loss. They should have professional nail care. They should be looking at their feet and legs every day. And they should be very alert to any early sign of injury, any early sign of trauma. And if they do sustain an injury, they should know to clean it, to protect it with the dressing, and to report it promptly to their care provider. That's primary therapy for the patient with lower extremity or arterial disease. Now, there are some additional therapies that are used for selected patients, and one is hyperbaric oxygen therapy. And this actually can be used to promote healing of an arterial wound. Typically not used by itself, so the patient may undergo revascularization, either bypass or angioplasty. Will definitely be placed on appropriate medications. Will be educated about tobacco cessation, about glucose control, and will receive hyperbaric oxygen therapy, at least an evaluation to determine if they're likely to benefit. Who is likely to benefit? The patient who has an open wound, the wound bed is viable, but the wound is not healing. So you go back to your class on refractory wounds, and what did you learn about hyperbaric oxygen therapy? You learned that it works by dissolving oxygen in the plasma component of the blood, so that anywhere plasma goes, oxygen goes. So you can see how that could be very beneficial to the patient who has diminished blood flow, but they still have blood flow, because then any blood that gets out to the tissues is hyperoxygenated and helps to fuel and support the repair process. So if the patient has dead black racing toes, it's way too late, right? But if they have a non-healing wound with some viable tissue, they should at least be evaluated to see if hyperbaric oxygen might be effective. And remember that when you send the patient for workup for possible hyperbaric oxygen therapy, they're going to test their tissue oxygen levels at baseline, breathing room air, and then breathing 100% oxygen. And they might even do a test dive to see how well oxygen levels respond to hyperbaric oxygen. So you never want to forget about that, because what's your job? Your job is to identify the patient who might benefit and to send the patient for workup, for assessment. Is the hyperbaric oxygen team's job to determine, is this patient a good candidate? The other thing that's being looked at in research studies is intermittent compression, dynamic compression therapy. There's one device called ArtAssist. And of course, this is very much like your SCD, sequential compression device. Well, how does that work? It inflates and it propels venous blood back to the heart. And then it relaxes. And during the relaxation phase, arterial blood flows in. But emptying the venous bed enhances the rate of arterial inflow. So that sequential, empty the venous bed, invite in the arterial blood. Send venous blood back to the heart, invite in the arterial flow. And some studies are showing some positive results, so you may see that used more in the future. Okay, the last couple of slides are about topical therapy, because of course the staff's going to say to you, and the physician's going to say to you, what should we use on this wound? How should we treat this wound? I want you to think of arterial wounds as falling into 3 different categories when it comes to management. Category 1 is when you have a wound that's covered with dry eschar. There are no signs of infection, and at baseline the patient has very poor perfusion, not enough blood flow to support healing. In that case, your wound management goal is maintenance. You're trying to prevent infection, prevent deterioration, maintain them just as they are while they undergo workup, while determinations are made about revascularization, while medical therapy is initiated. So we're trying to prevent infection. The best thing to do typically is to paint with povidone iodine to keep bacterial counts very low at the surface and to keep that eschar dry and attached and adherent. And then to leave it open to air or wrap it with dry gauze. So poorly perfused, wound bed completely covered with dry adherent eschar, no signs of infection, leave it alone. That's what you see on top. And actually, when we saw that wound, you'll see that right at the periphery, it looks like it's starting to separate because somebody has started using gel. Like, no, this patient's ABI is 0.42. We do not want to open this wound. We're going to paint it with betadine. We're going to leave it open to the air. We're going to see if we can't re-establish a completely closed wound. And we were able to do so. The wound on bottom falls into the second category. Second category, the patient has very poor perfusion, not adequate to support healing. but the wound is necrotic and infected. So here, I just want you to see how this one is different from this. So you have the wound that's covered with eschar, but it's seeping fluid. So clearly the wound is not closed. That eschar is not creating an effective barrier. So yes, there's a lot of necrotic tissue, but the wound bed is communicating with the environment, and you have clear-cut signs of infection. So the wound bed is poorly perfused, which makes you think, well, shouldn't we leave it alone? But then you go to point number 2. Is the wound completely closed by dry eschar and protected from the environment? No. Checkpoint number 3. Is the wound clinically infected? Yes. So if the wound is necrotic and infected, you have to move ahead with debridement because your goal is to try to prevent limb loss. Obviously, you'd also place the patient on systemic antibiotics. Patient on the bottom, very different situation than the patient on top. Now, we've said you need to debride, but would anybody want to get out their scalpel? I hope not, because that would be a very risky situation in which to attempt instrumental debridement, and you'd be violating the 2 contraindications. 2 contraindications. Is there active infection? Yes. Is the eschar stuck to the wound base? Yes, in many areas it is. No, we're not going to do anything instrumental, but could we initiate chemical debridement with Dakins? Yes, that would be a good choice. Enzymatic, we could, but it would be very slow. The third category is you have an open wound, or you have a wound that has sufficient perfusion for healing. Obviously, if that patient's now been revascularized and their ABI is now 0.72, it's like, well, let's get this wound healed. And you're going to move right down that D1-MOPI pathway. You're going to eliminate any necrotic tissue. You're going to manage bacterial loads. You're going to keep the wound bed moist, protected, standard care. What if the wound bed is open and the ABI is low? Let's say that you have this open wound, but the problem is the ABI is 0.42, the patient's still in the workup phase. It is too late to leave it alone. This wound is not protected by dry eschar. It's open to the environment. So you are forced to move ahead with all of your principles of moist wound healing. And see what's in bold? Studies have shown that complete elimination of necrotic tissue and ongoing management of bacterial loads are the 2 most critical elements in prevention of limb loss. So if the wound is open, go right down the D1-MOPI pathway. Once adequate blood flow is reestablished, right down the D1-MOPI pathway. Start with eliminating necrotic tissue. Decide the best way to do debridement. Make sure you're managing bacterial loads. Handle your exudate. Keep the wound surface moist. Keep the wound protected. All of those things. Now, one thing that we do a lot, if we have an open arterial wound, we focus on eliminating necrotic tissue, and we focus on controlling bacterial loads. If they're clinically infected, they're going on systemic antibiotics. And typically, we also use topical antimicrobials to keep bacterial counts low at the surface. Finally, you want to use occlusive dressings like hydrocolloids with great caution because we have no data regarding their safety in infected wounds. So typically, we will not use totally occlusive dressings in an ischemic wound. So in summary, when you're managing arterial wounds, your primary goal is to improve perfusion. Can we bypass them? Can we use angioplasty and a stent? What medications do they need to be placed on? All of that's done by vascular. We're going to work to educate the patient about tobacco cessation, about the importance of hydration, about tight glucose control. We're going to base topical therapy on the status of perfusion and the status of the wound bed. So if the wound is poorly perfused, it's closed, it's dry, it's uninfected, we're going to leave it alone. If it's poorly perfused but open, if it's poorly perfused but infected, then we're going to manage based on the principles of voice wound healing with a big focus on eliminating the necrotic tissue and managing bacterial loads. If the wound is open, or if we have now re-established adequate perfusion for healing, we follow the dealer modified pathway. Okay, we'll discuss all of this more when you're on site. It's a lot of content. If you have questions, give us a call. Time for a break. Thank you.